I gave up.
Hi.
I know.
We're live. Hi, everybody.
Hello, everybody.
Welcome back.
Welcome back, week 3. James Galore here.
Emily Scott.
Shay Suskin.
And we just wanted to touch base again and see how you guys are doing. Hopefully you guys can ask some questions. In the meantime, we got a couple emails already, so we'll address that today. Just talking about COVID and just other updates in our practice, testing, social distancing, what we think is hopefully working here in California, and comparing that to other places like New York, and those types of topics. So Shay has some stats if you want to read, like just from Orange County.
The daily stats. We're just checking daily on the Orange County Public Health website to see where we're at with things. So cumulative cases in Orange County so far, we're at 606. Orange County deaths from COVID so far is 10. That's updated today. So this was somewhat encouraging from yesterday to today. The cases that are currently in the hospital, yesterday it was at 94, and today that number is 67. And then an important number that we're following too is cases currently in the ICU. And that number also went down today. Yesterday it was at 46. Today that number is at 31. So that's one that we're really keeping a close eye on to kind of just try to get a sense of what our, how quickly, the hospitals are reaching capacity and that kind of thing. And it seems like we're still at the slow trickle phase, which is encouraging.
They said 3 of the 10 deaths were reported today, which is interesting, and 107 of the 600 cases were also reported today. So a lot of those numbers were from today. So we see this, we're seeing this more dramatic increase now.
Mm-hmm.
Right. And so there's a great website if some of you haven't seen it already, and please, if it makes you anxious, don't look at it. But there is great data out there on IHME is the organization. So I think it's the Institute for Health Metrics, University of Washington. Basically, you can plug in and see where we are projected at today and where our peak is going to be in terms of caseloads. So right now we're anticipating April 28th is in a couple weeks to be where the peak of where our prevalence of COVID is in terms of just disease and severity of illness. So we're a couple weeks away from that. Shay and I were just talking before going over that data and how there is a significant difference. Once again, these are mathematical models based on a lot of assumptions, but having seen what New York is going through currently and what we're seeing here in California, based on, once again, projections with a lot of assumptions, it's possible that because we've been very aggressive about social distancing and doing what we've been doing and disrupting our lives, that it could be very beneficial in making sure we have enough beds, ICU resources, and that's really the whole goal of this. So as of today, these are, once again, projections, it seems like that is paying off, and I don't want to be too optimistic, but continuing what we're doing is really the most important thing that we stress every week of social distancing and why our kids aren't at school, why all of a sudden we're homeschool teachers, homeschooling our kids and all of that. But that's the positive spin on what we're seeing so far. So hopefully that continues.
Yeah, so some hopeful projections, but I think these next couple weeks are going to be so critical to really figuring out if that slope starts to dramatically increase like it has in other places, or whether we can keep it a little flatter here, which we hope we can.
One of the things on that note, we wanted to do some updates on testing, and I had mentioned antibody tests, serology tests are coming our way, and we'll talk a little bit more about this and what that means for our current testing and maybe future testing. There's a couple labs that are going online with antibody testing, which is a blood test, different than the Q-tip, the booger collector that we've been using. And this is a test that really checks for antibodies in your blood to see if you've been exposed and have developed an immune response towards COVID. And it's a test that we can talk about a little bit. Maybe you guys can share your insight into this, but it basically will help us rule in whether or not you have an immune response to COVID, but not necessarily if you're actively infected. So that's a really big nuance there. So this is something where we could potentially in a few weeks really help people decide, one, if they're actively infected with the nasal swab PCR test, and number two, whether or not you have some form of immunity or have been exposed to it in the past. So a lot of patients have come to me and say, I was sick 2 weeks ago. Was that coronavirus? And I don't know. Your COVID test would be negative on a PCR swab, but we don't have, up to this point, any tests to check that. So I've been speaking with a couple local vendors, and hopefully, I don't want to give too firm of a dates, but in the next week or two, clearly we'll make an announcement. But I think something that we can deploy for people to really know where they're at, where they've been, and really help out with making those decisions, which are really huge for us as individuals, but as a community, how are we going to create policies to decide, where social isolation is really needed more aggressively than others. And once again, this is a little bit more of a long-term game. So.
Yeah, so that'll be important data to collect, and we'll be open to doing, we'll be encouraging doing those those types of tests once we have them available. But it's tricky. I think we need to understand that there's so much we don't understand about what a positive antibody test is going to mean. Does that mean that you're protected from the virus, that you can't get it again? We don't know that yet. I think that we're just still so early in understanding the immunity to this virus and how that develops and how long it lasts and what level of the antibody is protective or what level means that you just were exposed at some point. We're all, so it might be a little tricky to make firm recommendations on how cautious you should be once we have an antibody test in the beginning, but it still will be helpful to gather that data. So
absolutely.
that we can interpret it moving forward.
The other part of it too is how accurate is the test itself. So how many people that actually have the antibodies will show the antibodies on the test, and that's still, as the test is being developed and they're putting it out, that data is based, saying how well it works is based on testing it in a smaller group of people. So the more that we do this test, though, the more we can get more data, and then the more we can understand how effective it is. And so I think even though there may be questions about how accurate is it really, I still think there's value in us pushing forward and supporting this and moving forward with this kind of testing, because it's just so valuable. Mm-hmm. And these tests, maybe I don't know if antibody is too technical a word for people out there, who knows, but we run these tests a lot. So for example, if you came to see us and you wanted to see if you were immune to chickenpox, like because somebody in your family had it and you weren't sure if you had it when you were a kid, it's the same type of blood test that we run just to see if you're immune to chickenpox, or if you've had your hepatitis vaccine or your measles vaccine, if you're immune. So it's not a new invention of a test. It's just using it for this particular virus. So there's reasons to be optimistic or hopeful or trust that the data could be more accurate, because it's not like this new invention.
Yeah.
So.
Yeah. That's it in a nutshell. And a couple questions since we're on the subject of this. So we do plan on doing this testing in our parking lots. There is some question about down the road in terms of our practice, and we've discussed this a little bit, whether or not we would be able to do it in the office. At the very least, we would be able to do it in a parking lot is our goal. And the second question is volunteers to be tested for antibodies. The company that I've spoken with, they want people who have been known positive so they can validate positive patients. So if you know anybody who's positive and would feel like they would like to volunteer, you can contact us and we can get you more information on that. Regarding the virus mutating, that's still a question that hasn't been clearly answered. There's definitely been some minor mutations, which has been promising. And whether that does change your immunity to the virus in the long term is, once again, goes to Shay's point about there's still a lot of unknown, the months, years moving forward, how effective your immunity is towards this. So we don't have a clear answer of that. But the short answer is yes, the virus does mutate. All viruses do mutate. This one is slower than others, but that doesn't mean, once again, definitively gives us any guidance onto timing and effectiveness of vaccines and your specific immunity. So, yeah.
Another thing we could speak about is the accuracy of the respiratory or the nasopharyngeal swabs we've been doing. And we call that PCR. What that means is basically we're putting a Q-tip back in there. And if we pick up any copies of the virus, the virus sitting back there, what they do then is they take that and they kind of take out the pieces of the genome of the virus to show that it's there. And so the accuracy of those tests, we've been kind of back and forth. I think last time we said something about 70%, and we weren't sure where that number came from. And the company that we've been working with just sent us their accuracy data, and they said it was based on real world experience.
Compared to CDC cases.
Yeah, and that it was 98%.
99%.
99%.
Sensitivity, which means ruling out.
So if it's 99% sensitive, there's a 1% chance you would have a false negative, which is
a lot better than the
Yeah.
70% we were saying. So I mean, we heard that through outside sources, not from the lab themselves, about in general
how these tests were
right
on the whole, not to one particular lab.
precisely.
Right.
And so then what does that mean for you guys? I do think there's something to be said about the collection technique, and we're the ones doing the test. We're not in like a big volume where you have someone who maybe hasn't done it before. So I feel more confident in our swabbing.
Yeah.
And so I do think there's something to be said about the accuracy of the tests that we're doing. It's given me more confidence. And in that air, we kind of did this back and forth. We were saying, well, if it's not that accurate, then why are we even testing? And now we're kind of back to like, well, maybe we should be testing more people. It seems like Orange County, there's not like this dramatic prevalence, at least at this point. We're not looking like New York. And so maybe it does make sense to swab more people to have more clarity, particularly if we're talking about later, if we're going to put in this antibody test and they only want to look at the positive people, then maybe it makes more sense. People are asking too about, I don't want to take a test from someone else. Right. And so I don't know, what would you guys say about that? Like resource wise, like they don't want to use a test. We have so many gracious, amazing human beings in this world who are being thoughtful about other people. And
you were going to answer.
Oh, not that question specifically, but to that question, I would say I don't think right now for our practice that's really an issue. We have unlimited access to these tests. We have plenty of test kits here, and the lab is reassuring us that we can get as many more as we need right now. They're really, things are moving so quickly. Last week there was some concern of a limited supply of the reagent for the tests. I'm not hearing about that as much anymore, and particularly with the lab that we're working with. So yeah, this is a little shift in messaging from what we were saying last week, but James and I were just talking about this before too, and we're totally on board with.
I'll highlight.
Time to broaden. We're fine with broadening access to the test, and we want people. We're trying to make tweaks in our practice and the way we're doing things to make this test accessible. So many of you already know about this and are utilizing this, but to friends and family members potentially who are having a hard time finding access, we're finding ways to make that happen. So let us know. We think it would be really helpful to get a better handle, especially in communities that might not have, uninsured or others that might not have access to a test otherwise. We'd like to know where things stand. So let us know and we'll work with you. Yeah,
that's definitely available. And to that point, I think the more access people can have to it, there's just been a lot of barriers, I think, in the healthcare system in general. And, one of our goals has always been to remove those or make them less challenging. So feel free to reach out to us. We might not have the perfect answer, but at least we'll work hard on that. To her point about, having gracious patients really kind of withhold testing, even though they're symptomatic, I'll echo this statement that, I've been telling patients, the resources we have are not limited. We're concerned about taking away from others at this point. And if you're symptomatic, definitely at least consider it or talk to us and we can help figure out the answer for you. Maybe you don't need a test, maybe you do, but at least touch base with us. Asymptomatic patients might be a lower yield in terms of testing. If you have zero symptoms, it might not be as good of a test. But once again, please feel free to reach out to us. That's what we're here for, and we can clarify those answers. But don't feel shy about contacting us regarding that.
Yeah.
Cool.
Someone asked you about vaccines. I don't think that's coming for another year.
Months at the very least. Most likely a year, unfortunately. It takes a while to clinically validate, making sure that there's no side effects, making sure it's effective. virus mutations, all of those things.
So it's not hard to make a vaccine. It's actually, I can't remember the analogy that was used, but it was like, if you can pretty much quickly create the vaccine. It's the testing of the effectiveness that matters. So it's kind of the same thing with this antibody test, right? We have it, and now we need to go and use it in the real world to see. So when you read about there's vaccines and there's vaccines being tested, it means that they're in that early stage to see if they're effective. If the vaccine that's created causes more people to die, we don't want to, put that all over the place before we've tested it to be sure that it's safe and that it works.
Right. Yeah, that's exactly right.
The second part of that question was, does this mean this virus has been known for a while? And we're not at all aware of any knowledge of this virus before late December when it was discovered in China. So,
and they can so quickly create, like I said, they can very quickly create the vaccine itself. So that's just because it happened so quick that they made the vaccine doesn't mean that the vaccine is ready to be used.
Correct. Yeah, that I think gets lost in the headlines, because the headlines does read, I'm sure a company, they're all racing for it for obvious reasons. But yeah, just the headline that they found one or they created one, but that's really just
ready for
that's the easiest step and the quickest step, but the real bulk of work is in process right now. So that was it with testing, unless there's any other questions or you guys want to comment on that.
Testing question.
If I'd liked it tested, if I'd been infected, then would it be safer for me to go back to work? Yeah, I mean, that's kind of what we're talking about for everybody. Like if you have a positive respiratory swab here, and you then get the antibody test and it shows that you have antibodies, and then you also have no symptoms, and then later your respiratory swab turns negative, then maybe the testing has helped us assure that you are safe to go back to work. All that being said, what the CDC and Orange County Public Health has said about return to work is there's the three conditions. One is 7 days.
Removing isolation, not return to work.
Sorry, removing isolation. Yeah, that's not return to work. Sorry. Yes, because we're still on shelter at home. But it's 7 days with no symptoms, at least 3 days with no fever, and that you're getting better.
Right. So that's the clearance at this point. There isn't a negative testing protocol for the Orange County Public Health. Having said that, every employer and hospital system may implement their own specific strategy for return to work. So I don't want to speak on their behalf. Right. But that's the official. There's two pathways of clearance, and that's the non-testing pathway, and then there's the testing pathway of testing 2 negatives 24 hours apart. Is I believe the testing pathway. So I would default to your organization.
I think that is being utilized more in high risk settings. Like if you're a healthcare worker that's going to be around a lot of COVID positive patients, you might want to test negative, before you go and see a high volume of patients at a close distance. So it depends on how high risk your work setting is.
On a personal note, I would feel reassured. Once again, for me, if I tested positive for having it at some point or felt like I had it, and then second of all, had some type of antibody test a couple weeks afterwards showing I had some immunity towards it, I would feel reassured, feeling like I'd be at lower risk, not necessarily zero risk of going back to work. So it's all relative. It's not black and white, unfortunately, but that's why I'm using these words of relatively feeling reassured by that. So.
Someone asked what a fever was. I would say 100.4. What do you guys think?
So
say 101.
So technically it's 100.4 if you read it. That's the doctor fever. However, if you look at the CDC guidelines, subjective fever, meaning you feel like you have a fever, actually does count. So I think we mentioned this the first time, you don't have to go and rush and buy a thermometer to do it. I think subjective monitoring is fair. If you feel fine, most likely you're fine. If you feel like you have a fever, you possibly have a fever. So I think those are all reasonable metrics to follow.
Mm-hmm. Yeah, I've told a couple people to just stop checking their temperature because they're like, I'm 99.2, now I'm 99.4. Now I'm like, well, how are you feeling? Well, I feel fine. So they put the thermometer away because that's not what's important here.
Right. And that's our usual spiel. I think non-COVID times, but COVID times, that's something that I also still would be. Yeah.
So we're starting to get a lot of mask questions, which was perfect.
That was a topic. That was another topic. We have a lot of questions.
A couple of questions about masks too, so we can shift to that. But maybe real quick, there's just one simple question: is the antibody test ready at your office Not today.
Not today. We will definitely announce it. We'll blast it to everybody when it is available. I just literally over this weekend, 2 days ago, have been in communication with a lab called Genolite in San Diego. So we will see. They are approved officially on April 8th to start testing. Before then, it's under clinical trial status. They're still doing clinical validation. The test requires a blood draw. It's a tube. It's not a fingerprint. Not a finger prick. Those tests are also coming too. But just to go on that note, they quoted from their technical validation, and don't quote the exacts, but roughly 81% sensitivity and the high 90s specificity on the technical validation. And they are waiting on the clinical validation, once again, going from just the perfect environment in the laboratory versus clinical specimens, how that translates. But that is one lab that is up and coming. There's another one from Henry Schein that is doing, I believe, a rapid point of care testing. And I'm curious to see, once again, going on the accuracy and how accurate those tests are going to be and the pricing and all that kind of stuff. With Genolite, they assured us that it's covered by all insurers, whether it's Medicaid, Medi-Cal, Medicare, all private insurers will cover it.
What does that mean for Kaiser?
Kaiser, I asked HMOs and they will bill like HMOs. Okay. So supposedly all insurers, because of these emergent times, if you have any insurance, basically the lab will bill the insurance company and supposedly that they will run it, cover it. So that's what I was told. So yeah.
And then 82% sensitive, just to translate a little. What it means is that kind of like what we were talking about. So if I do 100 tests, if I have 100 people who have COVID, and they have antibodies to it, I will only find the antibodies on 82 of those people. Right. So that's 18 people that I'm testing who should have the antibodies there that I didn't capture. And then when he talked about 98% specificity, is that what you said?
In the high 90s.
So the specificity is like, if I have 100 people who do not have COVID antibodies, they've never been exposed, they've never had anything, and then I do this test, I might get 2 people who have shown that they actually have the antibodies, and it's not true, like it's wrong. So it's a false positive. So just so I can translate.
Yeah, I'll be a little geeky on this because it is important, and we can talk individually when we get to this point. But essentially, it's a good rule-in test. So what we will probably recommend is, if you're feeling sick, like if I have a fever for a day, it wouldn't be a good test to do right away. And your body takes time to make these antibodies, and roughly we're seeing like 3 to 5 days after you're infected to develop what we call an IgM. And the way I remember it from med school is the M means mad. So it means you're mad and angry. And so that's the acute phase of the infection. And then the G, the IgG is the longer lasting one. So you'll make these IgG antibodies and you're glad it's over. So that's the G. And so
you went to a really good med.
Yeah, it's a cast. That's all I give in the acute phase. So once again, we'll discuss this in more detail as we get it, but this test will be more helpful in the long term, let's say like 2 weeks after you've had your illness, and whether or not that really was, COVID plus or minus that PCR test. So that's a little more detail on that.
And I know we're harping on this, but one more thing I would say, like if you came in and you wanted to be checked that you were immune to measles, and I did your measles check, and then it said you were immune, and then you asked me what would happen if I went into a room full of people with measles, I would say that's not a good idea, right? So even though you're technically immune, even with things that are tried and true, you are definitely more protected than someone who isn't. There's clarity on that. But is it like 100% you won't get measles and you'll be fine? No. So that's kind of the way to think about this too. Like even when we have this tried and true, it's all about it's medicine. Nothing's 100%. So it's all about hedging risk, and I think a lot of us understand that.
Right. And once again, we can talk to everybody individually about this because it's a challenging thing to experience, not only think about, but understanding your risk and engaging your family, your workmates as we move forward over the next couple of months. It's something we do need to take in mind in how we conduct ourselves and in the community. So we'll do it on a case by case for sure. So that's more harping on antibody testing because it is interesting. Anything else on that? We'll probably get back to it at some point during this, but
throw out your questions.
Yeah, throw them out. So there's a lot of, so look at the masks. Great question on masks.
Should we all be wearing masks to
Here's
the
a-
grocery store?
That's a good one.
Um,
What's the answer?
and another good question: do you think that they're going to pass regulation that we are all wearing masks soon? And we're not at that point yet.
And it'll never be regulation, I don't think. It'll be a very strong recommendation, perhaps. Yeah, perhaps.
Right.
Sorry, I interrupted.
No, yeah. So that is a possibility. I've read some articles that the CDC is having some conversations about changing the recommendation on that right now. My understanding is the World Health Organization recommendation is to wear a mask if you're symptomatic. And you're going to be out in public. We've been talking about it, and I think our general guidelines are it can be a good idea to wear a mask as long as you understand its limitations and understand how to use it properly. So probably the biggest benefit to wearing a mask is to train yourself not to touch your face. And if you have a mask on, that just helps you to remember to not touch your face. A mask is not going to be helpful if wearing, yeah. We're trying.
Got you.
She's just illustrating. Thank you.
Wish I had a mask.
So that's probably the biggest benefit of it. If you're wearing a mask and you think that because of the mask, you don't have to wash your hands, you can get closer than the recommended, 3 to 6 feet to someone for a sustained period of time, then the mask is going to be harmful and not helpful. So the most important things are the hand washing, and the social distancing, not having sustained contact closer than 6 feet with people outside of your inner circle that you've decided who that inner circle is right now. And that's it. So the mask can be helpful to help you not touch your face when you're out in public before you had a chance to wash your hands if you're out at the grocery store. The mask, but we don't have definitive data at all that suggests that the mask is going to protect you from contracting COVID by any other mechanism. It's not an airborne disease. You're not breathing it in. You get this disease by touching your face is the primary mechanism. So
But is there
clarify that. So we
There's
have
a
a
question
discussion.
about
So this
that.
is a great question.
Yeah,
So
yeah.
there is, they do these lab studies, people sneeze, and
right?
it is airborne for 3 hours potentially. So clarify, because I agree with you. So we're not fighting. I swear.
Yeah, no,
They're
discussing.
fighting.
And we're
This is
fighting.
good. Again,
So-
we're
so yeah.
illustrating.
Yeah. So clarify what that means, because I think that's a great question that people will bring up. Like, I heard it's airborne, and so they're scared about that. So,
Right.
yeah.
I mean, I think just overwhelmingly the data doesn't show that that's the primary method by which it's transmitted. I mean, maybe if you're in a high risk setting where you're frequently like in a hospital doing procedures where this virus is aerosolized, where it's in the air, then you could be higher risk to contract it that way. But at as the weeks pass here, we're getting more and more data on how people are getting this, and it really seems like overwhelmingly it's droplet. It's more, it's with sustained contact with, closer than the 3 feet with patients who have it, and you're touching them, and then you're touching your face, or you're.
So like if I'm sitting here with you and you are coughing and you're like, and I'm not touching you, but you're coughing and we're this close, then am I at risk?
Certainly.
Right.
Then you are at risk.
Yeah.
Yeah. That's the social. That's why we say no more than 3 to 6.
Right.
6 feet.
And so then
All
the
the
other
time,
question
3
would be
feet, maybe a
too,
short
like
time.
in that scenario, if you are that close to someone and you have a mask on versus not having a mask on, does it protect you more? Like,
Not necessarily. So if it's not, once again, you're putting yourself, you have to be very, and this is what we're doing now, you just have to be mindful of the situations you put yourself in. So that's why we've been so aggressive about social mitigation or mitigating with social distancing, is that, to prevent this confusion, like this, it's not clear to me if I'm wearing a mask, but I'm, they're coughing and we're sitting this close. We shouldn't be in that situation
Right.
to begin with. So once again, we should be distanced. If you're sick, you should be not talking to anybody. You should, have the thoughtfulness to be able to do that. And so if we start at those steps, then this whole mask thing becomes less of an issue.
But let's just say that you're not in that ideal situation.
Sure.
So now you've gone to the grocery store and someone comes up next to you and starts coughing and you running away, but like it's too late and they coughed in your space. Like, does having a mask on in that situation make you a little safer than not? And that's maybe why the CDC is starting to talk more about masks.
Maybe, but I also don't imagine people running around in grocery stores like coughing
on
at people.
Right. No, I know, but I'm just saying when you feel like the world is sort of, you can't control everything when you leave your home.
Fair.
And so if you feel like you're going to be in this situation and you can't control the person next to you and that they're sick and they left their house and they're coughing and, you know, and they coughed this cloud and you walked through that cloud 1 second later.
True. I just want to reiterate, those are really, in my mind, fairly rare situations. And I think, once again, just mindfulness, if as a community, we're just mindful of that and that we can avoid those situations. I agree, we can't control everything around us, but those to me are exceedingly rare instances and that we can avoid them. And I think just being mindful about it and respecting others, I think if we can do that and ask that of others, then that's why we're all in this together, and that's why it's being repeated over and over again. And will that happen somewhere? I'm sure it has, but I think, you know, dwelling on that what if can be really paralyzing. And once again, wearing a mask, if that helps, I think it's great. I don't discourage mask wearing, but I also won't blanketly say that it's going to protect you or minimize your risk. And I just think feeling comfortable with social distancing, washing your hands, and potentially using a mask as a reminder, hey, I gotta stay away from others and I gotta not touch my face. Focusing on that is really important.
Yeah, I want to reiterate that training yourself not to touch your face is no small thing. Like,
that's hard.
The mask can be very helpful for that. And so it's not a bad idea to start wearing it when you're out in public places, so that when you're outside of the house and you're in this, you know, less controlled environment, that you touch your face less. That's going to be helpful to decreasing transmission. A patient emailed in specifically regarding the mask question. If I need to be around my grandkids right now and I'm older, should I be wearing a mask? I feel like my response to that might have changed just as we were having this conversation, because that's a situation where that exactly what they're just talking about. James said this would be very, very rare, but that's a situation where it would be more likely that you're going to get coughed on is when you're around kids. They just can't, you know, especially depending on how young the kids are. I'm thinking of my 3 and 5-year-old at home, and they don't understand social distancing. And if they saw Nana right now, they would be coughing in her face. So if your grandkids are coughing, it is really safest for you to not be around your grandkids right now if you're at all able to do that. Some families are not in that situation and you absolutely need to be around your grandkids. And, you know, wearing a mask might not be a bad idea. Again, really frequent hand washing. And trying to be aware of not touching your face.
So here are some questions that James and I have been having this debate, right? Like,
Which
so,
one?
well, there's this,
It's a couple of the ones about are we talking about masks?
Well, yeah, my mom is saying if you're wearing a mask, is it protecting others because you're asymptomatic? And then someone else is saying there's this MIT study that says it can remain in the air and go 26 feet. So what do you say to that?
I think those are all laboratory and interesting studies that I wouldn't dismiss, but from a mass public health perspective, what we've seen is still what Shay alluded to before. The vast majority of transmission is really just respiratory droplets. And that because of our culture, and this is interesting when we look at Asian cultures and the face mask, the culture of wearing the mask is a way of training ourselves, once again, potentially just actually as a culture, as a society, to behave differently, right? You know, not shaking hands anymore, not touching our face. So these things, when you multiply that exponentially, can do a huge thing to prevent and lower the risk of transmission. Regarding the studies, are there validity to studies? So yeah, when you tag and spray a molecule and it can go, you know, farther than 6 feet, and that's an antiquated study done from the 30s. Based on, I forgot what it was based on, but it is an old study based on the whole 6 feet measurement. Is it possible? Yes. But once again, it's about that risk and the likelihood of that and how that would affect us. And so at this point in time, it still would, for me, my recommendations would be, you know, the masks are still, once again, okay to wear, and we wouldn't discourage anybody from wanting to wear a mask. But just understanding the reason for the mask isn't necessarily to prevent yourself from contracting the disease. And if you're asymptomatic, I know the CDC recently mentioned, I think yesterday, about 25% of asymptomatic people being potentially transmissible to others. Once again, is the mask enough to decrease spread? Once again, if you just step back a little bit and say like, hey, if you just stay away from people, don't go out if you're sick, and just wash your hands, those enough will just dampen out so many of the contagious risk factors. So once again, the mask, I still think it's okay to wear a mask, and we might start recommending it further for the reasons we stated above. But once again, I don't want to put a false reassurance out there. If you're wearing a mask, you won't get it, or it's that protective, and that we should all be wearing N95 masks. There's been a lot of studies in hospital workers where there's protocols. If I'm doing a procedure in a room with a sick patient, aerosolized, you're in a bubble essentially. But if you're in our office, is it reasonable for us to just wear a surgical mask? It actually is. We wear N95s, but it's reasonable to wear surgical masks. So that's where I stand.
And so in that point though, like if you're going to be out and there's the chance that you will be within 6 feet of someone.
Sure. If you feel that's a concern.
That's fair. Like we're putting on a mask with asymptomatic people who are within 6 feet of us in the office because we're kind of getting in their space.
Well, they're coming to a healthcare space, so yes, I feel.
Yeah, but they're asymptomatic. They're coming to see us for other acute issues, and we're still wearing a mask. So it seems like, I don't know why, like if that's the recommendation for healthcare workers, why isn't it the recommendation? And I get it, right? Like,
well, don't you think that's more if we're doing a physical exam, if we're getting in there,
we're
getting less than the 3 feet and the volume, which we're lucky, we're lower volume here. We're able to do so many of our visits by phone, but I think in healthcare in general, just the risk of transmitting it from patient to patient.
When you're in the office, the reason you're coming to our office right now is because we need to get close to you, and for us, we want to minimize any risks.
Right.
And so I'm wearing a mask because we're like this, and so even if you're somebody who may not have acute symptoms, I think it's, for me in a healthcare space, being in close contact. Once again, we're not social distancing. We've taken that out. So therefore you should wear a mask.
Right.
So if you're practicing social distancing.
That's a good point. If you're in a situation where you can't practice social distancing, then you should wear a mask.
Right. And once again, that's why the recommendation is we should be social distancing, because that's been the most effective thing out there from a public health perspective. And so, so once again, if you can't social distance for whatever reason, I think a mask is very reasonable.
So we haven't touched on yet, maybe last point in the mask discussion is type of mask, because there's still some questions about that. And it is still true that the hospitals could potentially have shortages if they get the surge that could be projected. So I think medical masks, surgical masks or N95s are not necessary or appropriate for outside of a healthcare setting. Do you guys see situations where those would be?
I mean, I think if you've already had one in your house and you've already used it and you're carefully reusing it, but if you're like going out and buying boxes of them and throwing one away every day and reusing like that, or not reusing, that just seems kind of sad.
Right. And if for some reason you do have you bought those or had some N95 masks or surgical masks, and now you're not using them and you have them laying around, UCI is doing drives to collect that kind of equipment. So there's information about that on the UCI Health website. But yeah, I mean, the hospitals are really trying to, gear up as best they can and get donations of any medical masks or N95s that are out in the community that aren't being used. I agree. If you have it and you've already been using it, so it can't be donated.
Right.
So it's not going to hurt.
Don't get mad if you see people in the grocery store with
with
a surgical mask on. Like, don't be angry.
No.
But yeah,
not what anyone needs right now.
Totally.
But if you have them, the hospitals can use them and we'll take them.
Right. Yep.
Good point.
Good point. I think those are a lot of the questions. So one of the questions, since we're still on, scarf, homemade masks. You guys want to speak to what are your thoughts on?
I think that would be appropriate. That's gonna fulfill the goals that we've been talking about here of somewhat minimizing anything that you would cough out, but most importantly, training you, just making you more mindful and cautious and aware not to touch your face and to take precautions. Yeah.
I'll go up. There was some questions about, and we we're going to talk about this anyway, was Plaquenil, hydroxychloroquine, and treatment for COVID. There was somebody who mentioned that they're physician told them about how malaria in a Z-Pack is curing it. I would be very, very cautious in speaking such strong language. At this point in time, there has been an emergency use indicated for people in severe hospitalized states or hospitalized states to use it. There are very small studies suggesting that it does reduce the viral load and reduce coronavirus in your system by taking both hydroxychloroquine and azithromycin. However, having said that, that does not mean we should all use it. And there's multiple reasons that we can start talking about that. But one is we really want to reserve those for people who could potentially use it. And so really, this is just a clinical study for really sick people right now, is the way I would put it. Second of all, there are tons of people who need it for conditions such as rheumatoid arthritis, lupus, that it's proven to help and benefit those people for. So we really want to make sure we're mindful, once again, of using the medication appropriately. And last of all, if I have a cold and I know it's COVID, but I feel fine, I don't think I should take it if my body is going to get rid of it naturally already on its own. So it's a lot of fear, which is totally understandable. But we're really using it at this point in time, potentially for people who are really sick. And if there are clinical studies that, well, they're already being done across the world, really examining how effective this really could be in really preventing mortality, that's the next question. So it's great that it can reduce the viral load, but does it increase significantly the mortality, morbidity, resource of ICU, all of those things? Those are big questions that still need to be answered. And for us to just throw all of that to everybody who wants it would be disastrous on many levels. So there's a lot to be said on that. Luckily, hydroxychloroquine and azithromycin are very affordable, easy to manufacture medications. But once again, just like everything else, if there's a surge, we won't be able to meet that surge of need. So there's potential that it might be helpful, but I definitely wouldn't prescribe it to people if someone came up to me with COVID and they look fine, they feel fine, they're not hospitalized. In an outpatient setting, I do not think at this point in time it's indicated. That might change later, but at this point in time, it's not something I would recommend.
At the risk of saying something stupid, and you guys tell me if this is a stupid thing to say, I just wonder if you were to get COVID and fight it off naturally, if for that experience, your immune response might be more robust. Whereas if you throw all these things at it, are you then getting in the way of that? And so thus, therefore, we should save those things for people who are not fighting COVID appropriately with their natural immunity.
Absolutely.
Right. And this is a broad discussion about antibiotic use and what we've always talked about in general and what we've seen. This is not related directly to COVID, but, just that, medication use, how should we let our bodies naturally fight things and statements I hear all the time, which is, I say it to myself all the time, I can't be sick right now, right? Like I have things to do and I need to do X, Y, and Z. Well, sometimes your body just needs to go through it, and that might be the better thing. And once again, I don't have an exact answer, but that's my personal.
You can just be organic.
That's true. That's true.
James looks like he loves that analogy.
I'm GMO.
You're totally GMO.
I'm GMO.
You're a
in a bad way. But the short answer is it may be beneficial, but I definitely would not label it as curative, nor would I prescribe it at this point in time.
And we're all doctors and have readily access to it, and none of us have it in our house.
We did not stockpile it.
We do not stockpile it in our pharmacy here. It just doesn't make sense.
Yeah, we're giving it to people. We do have a lot of patients who need it for rheumatoid arthritis and lupus, and we're trying to advocate for them to get it. That's our answer on that. Let's see.
Someone asked if I had a cold last winter, and I don't know what that means. Meaning
I saw that question
December?
too. I wasn't sure if that
Could it still be
when
COVID? Should I
last
do the
winter?
antibody test? And the answer to that is maybe. I don't know. We didn't really see it here till
until January.
Well,
So I don't know. It depends when you were sick, and the antibody test could be really interesting. And so I don't know how to answer that.
That's a hard
You have
one.
to know more about what last winter means and what your travel history has been. And,
Right.
I don't
It's
know.
less likely. I mean, if you look at the epidemiology or the statistics of how this happened, really the first case that was diagnosed in China was in December. And so statistically speaking, it's highly unlikely that it was prevalent here in significant numbers during the winter time. And once again, I don't know the clarity on that, but just very unlikely, not impossible, I guess, but unlikely.
Let's see.
Warm liquids helping prevent the virus. I'd say no to warm liquids preventing the virus. Once again, touching your face, just don't touch your face unless you wash your hands. We talked about ibuprofen before. That's a little controversial still. At this point, there's been no real large studies to say you shouldn't take ibuprofen. I believe Cornell is not using ibuprofen in their hospital at this point in time. Based on that, they're being a little more aggressive.
For the super people.
Right, in the hospital, correct. So in the hospital setting, they're not using ibuprofen. They're just being more cautious. At the end of the day, if you don't want to use ibuprofen, it's totally reasonable. In my opinion, you don't have to treat a fever anyway. It's really just feeling crummy and you want something, then I think taking Tylenol is fine.
Tylenol, I was just going to say, there is no known risk to Tylenol, so that question included both. And Tylenol, there's no concern. So if you are okay trying that instead of your Motrin, maybe go with that first.
Also, though, my holistic doctor side comes out with the maybe the fever can be helpful a little bit, and so I keep saying to people, if you have a fever, treat it because you're miserable and you need some relief. But if you are okay and you can hunker down and be with your fever and love your fever, then it's actually there to help you. It's a natural antiviral.
It's what kills the virus, is what I tell all my patients. We evolved to do that, and so if you. Once again, it's a totally comfort level and a personal decision, but if you can deal with it, it's reasonable. And one of the things that in my emergency medicine background, there's no number that you need to be worried about in terms of, there's been no documented case of brain damage secondary to fever. People get fevers from an underlying illness that does cause significant disease, but it's not the fever. And so, focusing on fever is not something I would worry about outside of just knowing that you have one. And if you feel crummy, then feel free to treat your crumminess, I guess.
So the other question about the NSAIDs, meaning ibuprofen, Aleve, naproxen, these are all kind of categorized together. I've had a lot of people who have arthritis or migraines, and they're like, I can't take it anymore. I'm in so much pain. I stopped taking my Aleve or my ibuprofen. It's okay. It's okay. If you're not sick with symptoms of COVID and you're taking this for other symptoms, there's no reason you can't do that.
Right. And even if you are sick with some cold symptoms, again, maybe just talk to us about the risk. If it seems like a mild cold and Motrin is all that works for your migraines or for your arthritis or whatever condition you've got going on, it might be the benefit might outweigh the risk, and even in that case, if you've got some cold symptoms.
There's a question about high risk factors. Somebody emailed yesterday about that as well. People who have asthma, if we can clarify who's high risk, what that means. Should they do anything differently?
Yeah, the question specifically asks, previously it was higher age groups and those with pre-existing conditions. So pre-existing conditions we can talk a bit more about, but definitely still we're seeing that trend that those that get more severely ill from this and need to stay in the ICU are still on the whole. Those in older age group above 70, so that's certainly a risk factor. And then any underlying, the big ones are conditions that would suppress your immune system. So cancer, especially, any recent chemotherapy or medications that suppress your immune system. If you have an autoimmune disease and you're taking, medications that are immunosuppressants, that's going to put you in a higher risk category. There's some other underlying medical conditions that affect your immune system, your ability to fight off conditions, like diabetes is a big one. Especially if your diabetes if your sugars have been higher recently, then that's going to affect your immune system more. And then beyond those diseases that affect your immune system, things that affect your cardiorespiratory system. So heart disease is going to, congestive heart failure, things like that are going to make you higher risk. And then lung disease. So COPD, asthma. I would say even if your asthma is mild, and you're not using regular daily controller inhalers, you'll be lower risk, but still, your lungs have that tendency to to spasm when you get sick, and that does put you in a little higher risk category.
I just had a conversation with a patient this morning who's not left his apartment in 2 weeks because he has a history of asthma, which is actually mild and controlled. And I talked him into going for a walk outside because what we talked about was that the movement that you get, the activity, the movement, the keeping your body in motion is going to help your immune system more, the sun, than the small risk of you going out in the community for a walk. So keep using that judgment on, like, if we can get out. Now, it seems like we mostly have to stay contained within our small little bubbles and stay away from people when we walk, but it's worth it.
Yeah.
Go out and get some movement outside.
Yeah, thank you for making that point, because I think that applies to most of the conditions we even just talked about.
Exactly.
You know, like if you can get outside safely, there's so many health benefits to getting outside for a little bit every day.
Yeah, just to walk around the neighborhood, and once again focusing on social distancing and I agree 100%. Just getting out of the house in a safe way is incredibly healthy and incredibly important. So I definitely would discourage people from hunkering down at home unless clearly you're ill and should be. But yeah.
How about this question? If I have been quarantined for 3 weeks and other family members have been as well at a different location, would it be okay for us to get together? That's such a good question. We were just trying to figure out, like, can we do a birthday party with, like, people far away from my son and keep them, their grandparents far away? What do you think? If we've all been quarantined for 3 weeks.
Once again, that's a tough one. That's a judgment call. I think social distancing should still apply. I think we start relaxing these a little bit, which we will be, I think, hopefully, in a few weeks, in a month or two. We just have to be really aware of what we're doing and how we respond to that, not only individually, but as a community. And so what risk are we putting ourselves into by doing that? You can have a dinner party potentially and have everybody 6 feet away. Is that something reasonable to do?
Then you're sharing food. If you're
right? No, I agree.
Around,
so I don't. It doesn't. I think you're exposing yourself to risk that at this point in time, it's a little too early. I think we all have cabin fever, and it would be nice to say, I wish we could do that, but I don't think I would recommend it.
I think it's important, if you haven't already, to really get clear on who your circle is, and try to keep that as small as you're able to, as you're reasonably able to, and that's your people now.
This isn't going to be forever, so
no, this is all temporary. It's painful. It's on multiple levels, but I think the more we can get through this together, the more effective all of this is, and will pay off. Hopefully, for sure. Regarding the case, a question about the case in December in China, there's no way to know if that's exactly the first case, but that's definitely the first documented case.
Sorry, I'm scrolling up here. On that same note of, can we start getting together with other people who have quarantined? There was a question about, I'm in a I lost it here.
I'm in a
multi-generational household, and
question,
sometimes we have.
Oh no, maybe not.
It was farther back. I can't find it now. But if we have teenage visitors over, and I did mean to address that question, because that was. You shouldn't be having teenage visitors right now. I know. Here we go. Multi-generational household. How to deal with teenage visitors. Currently, I stay in my room, but concerned for using kitchen after visitors' use area. I know it's super hard on our teenagers right now. Ideally, they would be sticking to these guidelines and staying in their circle, staying in their own house. You're doing the right thing, I think, by if there are outside visitors outside of your family circle coming, kind of trying to isolate, because you just don't know. And then, if those surfaces can be disinfected afterwards, especially. So what a lot of people are doing, what I'm trying to keep up with in my house right now is, even though we're mostly just staying at home just with us, once a day trying to disinfect as best you can, like the high touch surfaces, doorknobs and tabletops and things like that. That can be one measure that can help. So maybe consider doing that if there's visitors in the house, which again, we don't recommend there being visitors in the house, but if it's unavoidable, try to disinfect the doorknobs and light switches and high touch surfaces afterwards can help decrease risk.
That's awesome.
No, that's great.
I need to disinfect more.
There's a question on herd immunization can be effective in reducing the virus' ability to spread. This is something, unfortunately, we're going to have to, wait and see over the long term. Right now, that's what we're doing is just slowing the herd immunization, right? So that's the whole flattening the curve. Eventually, a lot of us will have been exposed to this at some point over the next year. It's just a matter of making sure we do it in a very controlled way, I guess is the way to say it, and hopefully minimize it as much as possible. If we can prolong it enough that a vaccine is available and effective, then clearly we won't need herd immunization from the native virus, and we can get immunization from vaccination. But yeah, that's a moving target, and it's hard for anybody in the world, not even just the U.S., to really support herd immunization from, where we're doing the social distancing to prevent just a rapid increase, since it's so contagious, if you will.
One quick point that I haven't talked about yet, a patient wrote in with this good suggestion. Well, last week we ended kind of talking about things you might be able to think about doing in your community if you're able to help higher risk populations around you. And one thing that she wrote in and recommended that she had done this week that felt really great and was easy to do was donating blood. If you're, if you medically qualify to be able to donate blood, all of the blood banks are pretty low in supply right now, just because nobody's, getting out and about and doing that kind of thing. So UCI has some centers where you can do it. Again, you can look at UCI Health, and they have days that they're doing it. They're doing it in a safe way where they're complying with social distancing and keeping it clean and sanitary. But if you're able to, if you, let us know if you're not sure if you're able to. We can talk through the qualifications with you, but that can be really helpful and something that's well needed right now. So
yeah. So other questions about
my sister said, so we can tell our teenage boys their aunt says they can't go see their girlfriend.
Yep, blame it all on Auntie Emily.
It's my fault.
Yeah.
She'll take it.
That's true.
I'm used to that.
Yeah.
Let's see.
Serum out of it more widespread. Okay.
How long COVID-19 lasts on surfaces.
Yeah, there's a study, I forgot the exact hours, but it's on the hours and days, depending on the specific surface specifically.
It does seem like I'm reading more and more 3 days. Initially, we were thinking up to 9, but it seems like 2 or 3 is maybe more likely.
The question then is it infectious during that time? Really hard to say. So once again, just defaulting back to what we keep hammering over and over again, if you just really diligent about washing your hands, covering, not touching your face if you haven't touched your hands, all of these things, then it just, once again, will just minimize or eliminate that risk, no matter what surface you happen to be touching. And if you're diligent about just washing your house regularly or what surfaces you have, then it shouldn't be an issue as much about how long it lasts on those surfaces.
I want to ask a question a little back there about the stats, which we did go over those at the beginning. If you're ever curious or wondering in between the weeks, the Orange County Public Health website, if you just Google Orange County Public Health COVID stats, every day they're updating those. So just quick.
I feel is just hospitalizations, right? So this is a very mild disease, and also just stepping back a little bit, just remembering, the vast majority of people this is really, mild flu, cold. And so we're just really trying to prevent the percentage in such a short amount of time of getting really sick. And to Shay's point earlier, the older patients do worse in terms of mortality, and they end up, have a higher risk of dying. There is, the middle age group, but you still get hospitalized. There's a decent amount of people who end up on the ventilator, get sick enough to be in ICU, but they don't die, have highest risk of dying from it still compared to older patients and people with underlying disease. So once again, everything we're doing is just to minimize all of this from happening.
There's still more questions coming in. Mm-hmm. Hand sanitizer is not good for your hands. Oh, well, it can make your hands pretty dry, but I think it's worthwhile to keep using it right now.
Right.
You don't need to use a large amount.
Right, still a drop.
A tiny drop is all you need.
And one thing I think we mentioned this, I think last week, but the coronavirus is very easy to kill. Like, it's not this robust thing. And, it being contagious is different than being strong. Mm-hmm. So really just soap and water. We mentioned this before. If you just wash it 20 seconds, soap and water, nothing fancy, you'll actually eliminate it. There's tons of cleansers out there that can easily clean and disinfect. So it's not a very robust virus. It's just contagious. We've never seen it before. Those are just the really big factors that have made this so damaging for the population as a whole, but it's not very strong.
I think we should wrap it up.
Let's wrap it up.
We've been
30
talking for
seconds.
59 minutes.
Yeah. Thank you, everybody. We'll do this
Bye.
again. Feel free to
Nice
share
to
this.
see all your
Yes.
messages
Continue to write
in
us
here.
your questions so we can make these as useful for you as we can.
We'll see you guys next week.
Bye.
Bye.
Hey, nice work, everyone.
I need to wash my hands.
Yeah.